Good afternoon, everybody. Laura Young here from the Department of Psychiatry at UT Tyler Health Science Center and the CPAN and PeriPAN program. I'm so glad that you're joining us today for our presentation from Dr. Shotwell and from Jonathan Adams. Dr. Shotwell will be providing information on obsessive-compulsive disorder assessment and treatment in primary care, specifically addressing the needs of children and adolescents in this area. I do want to introduce you to Dr. Shotwell. Let me stop sharing here just a moment. And let you know we are recording this session. So Dr. Shotwell is here. He is a board-certified child and adolescent psychiatrist. He is currently working as an assistant professor of child and adolescent psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of Texas Medical Branch in Galveston. His primary role at UTMB is serving as the medical director for the UTMB Texas Child Health Access through Telemedicine, also known as the T-Chat program, another one of the initiatives that is available to help improve the mental health of children here in Texas. And that program is fully funded, just as CPAN is, through the Texas Child Mental Health Care Consortium. And we do have Jonathan Adams here. Hey, Jonathan. Jonathan is a fourth-year medical student at UTMB. He will be presenting with Dr. Shotwell today. He's in the process of applying for residency for pediatric medicine and psychiatry. His career interests primarily lie in improving access to and quality of behavioral care to patients from underprivileged backgrounds. So I will turn the screen over to Dr. Shotwell. I do want to remind you folks that we are recording this session and we will be posting this to our YouTube page, hopefully by the end of the day if I get to it. If not, I'll be doing that tomorrow. So I'm going to take myself off camera and turn this over to you, Dr. Shotwell.
All right, thank you so much. And thank you everyone for joining us for this rescheduled session. I apologize for last time we were scheduled to present, but we had a hurricane moving through our area, so we had to reschedule. And so I appreciate you taking the time to join Jonathan and I today. So let me just take a moment and I will share my screen and presentation. Just want to confirm you all can see that before I move forward.
Looks good, Dr. Shotwell.
All right, thank you. And in the spirit of full disclosure, I can't see you all while I'm in this mode. So if you need something or if you write something in the chat, we'll have to address that at the end. All right, so as Ms. Laura mentioned, we're going to be talking today about obsessive-compulsive disorder, assessment and treatment in primary care. Sorry about that. I was having trouble getting the slide to advance. Okay, so Jonathan and I have no relevant financial disclosures. As Ms. Laura mentioned, I work at the University of Texas Medical Branch as a child and adolescent psychiatrist. And Jonathan is a fourth-year medical student who is applying for psychiatry residency. So here are our objectives for today. We're going to start by having Jonathan review a case of pediatric OCD that I actually saw through the T-Chat program. We're then going to take a look at the signs and symptoms of OCD. We will discuss the differential diagnosis for patients that are presenting with OCD symptoms. We will review the DSM-5 diagnostic criteria for OCD. And then we're going to also review some screening instruments that can be used when patients present with OCD symptoms. And then finally, we're going to summarize some treatment options for OCD, including both pharmacologic and non-pharmacologic options.
All right, am I audible to everybody?
Yes, you are.
Okay, thank you. All right, well, I'm Jonathan, and I'll be doing the case review portion of this presentation. So the patient is an adolescent male who presented for a telepsychiatry evaluation via the T-chat program. So this was an initial visit for this patient, at least on our end. And he was accompanied by his biological father, whereas his mother is the patient's primary caretaker. I think we advanced the slide a little early. There we go.
I'm
So
sorry
he had
about
recently
that. I'm
moved.
having trouble getting it to advance the way it should, so apologize for that, Jonathan.
It's all good. So he had recently moved to the area from out of state, which is why he was doing an initial evaluation. And so what we know is that the patient has a history of developmental delay and is in some kind of special education courses, but the father is unsure of the patient's IQ. We also know that he has a history of language delay and auditory processing disorders. And so the chief complaint for the father is that my teen refuses to shower and that he has anxieties. And so to paint more of a complete picture on this is a 15-year-old child coming with his dad. And so dad's not really the primary caretaker and is not quite as tuned in into the patient's medical history as mom may have been. So our full history is somewhat limited. So we do know he's in special ed courses, but we have a minimal idea of to what extent and how well he functions generally. But these are the dad's chief complaints. And if we can move on to the next slide. All right, so here are, so the father talked about anxieties, and here are the ones that the father reports as well as the patient. So he worries specifically about developing an ear infection. And there are some factors in his medical history that may have contributed to this anxiety. He had ear tubes 4 times as an infant, and he had some hearing deficits that may be part of the reason why he has this language delay. He also had like a particularly traumatic experience where a moth flew in his ear and got stuck. So he visited the ER, and when talking about it, he reports significant pain and that it was particularly scary for him. But he's also had a swimmer's ear infection. So this patient has a lot of reason to be worried about his ears based on his past experiences. And the way that he responded to these anxieties is avoiding any activities that involve water near his head. And that went to the extent of refusing to even wash his hair, in addition to like things like avoiding swimming. So we can go to the next slide. And he also had a specific fear about being allergic to foods and choking. So some of the things that may have contributed to this for him was that he has self-reported allergies to bananas, eggs, peanuts, shellfish, along with so many other things. So he has like an entire list of foods that he believes himself to be allergic to. But he doesn't report any history of anaphylaxis or particularly strong allergic responses. He does, though, have a fear of his throat swelling and choking. So he's aware of anaphylaxis. It's not something that has happened to him, but it's something he's worried about. And so to alleviate this, he avoids new foods and is very severely restricting in his diet. And he also needs an above normal amount of reassurance that his food is safe and has not been contaminated. And then we can go to the next slide. He also reports some fear about being bullied. So it's not so much that he has a general fear of new people and social situations, but it is that he particularly is worried about specifically being bullied. And so some of the contributing factors to that were that he had a recent move. He has experienced bullying in the past, and his developmental delay is likely something that he was bullied for. And so he does avoid social interactions with his peers entirely and does not want to attend school at all. He's a very isolated child. And then going to the next slide, he also has fears about germs or getting sick and contamination in general. So, I mean, this was happening during the time where COVID was happening. So we had a lot of social reasons to be worried about contamination. That was something that was in the general population as well. And he also had a peer who developed pink eye, and that was something that was very concerning to him. He was very worried about that spreading to him. And he does just have a tendency to Google illnesses and self-diagnose. So this is somebody who has a lot of health anxiety. And some of the behaviors that result from this are excessive hand washing, refusing to touch the toilet or trash cans. And with every bowel movement, he would use half a roll of toilet paper to ensure that he was properly clean. And then if he suspected that a peer was sick at school, he would completely refuse to go to school as well. So he was doing a lot of isolating behaviors towards this end as well. And so what were the patient's perspective of his symptoms? So the chief complaint was listed as multiple anxieties. with his top worries being food, allergies, ears, germs, asking teachers for help, bullying, and then of course COVID, which was prevalent at the time. And his response to these was quite problematic. He was severely limiting food, avoiding water towards his head, washing his hands in inappropriate amounts, and experiencing like a lot of isolation and difficulty socializing. And so while we know from the title of this presentation that we're likely looking at an example of OCD, we have to pay attention to how our patient and the father portrays their symptoms. They're not going to come to you and necessarily say, oh, I'm having obsessive compulsions. They may report their symptoms as a collection of anxieties, and the responses to these anxieties may feel rational to them rather than being described as compulsions. And so we can go to the next slide. And so he does have a past psychiatric history. He was treated by his PCP for anxiety in the past with a sertraline dosage of 50 milligrams daily for 1.5 years. There was intermittent compliance with this, with no change in his symptoms, and he denied any side effects. And yet, this dosage was never changed over the course of 1.5 years. His compliance was never addressed, and he did briefly meet with a counselor or a therapist. He only attended a few sessions, and there was some talk with this counselor and with a therapist about a possibility of autism spectrum disorder. But it's notable to really point out that he had an ineffective dose that he wasn't compliant with for over 1.5 years. And despite there being no side effects, there was no increase in his dose. Sertraline is not limited to 50 milligrams daily. And so despite the lack of effect, there was no modification to the regimen. And then it's also kind of worth noting that he did have all those fears about food allergies, but he never actually received any formal testing for food allergies to find out how rooted in reality this might have been. So in the past, the management of his anxieties seems to have not really been quite effective, which probably leads to today why he may not have a diagnosis of OCD, even though we suspect it highly at the age of 15. And so we can go on to here we go. So his past medical history, he had scoliosis and, as we say, like the self-reported food allergies with no formal testing. And then he also had several ear tubes in the past. Developmentally, he does have recorded speech and language motor delays, and he had received speech therapy and occupational therapy. And then in education, he received special ed throughout 10th grade. But we have limited information about the specifics of all this. Family psychiatric history, his dad, the father, does have social anxiety disorder, and he is in therapy for that. And the paternal grandmother as well also had social anxiety disorder with minimal knowledge about the treatment status. So he does have a family history of anxiety. For our mental status exam, he appeared okay, casually dressed, didn't make very good eye contact, and he was very pale. His mood was okay with a flat affect, with monotonous and mumbling speech. His thought process was concrete, though in content there were a lot of preoccupations and obsessions, as noted by his complaints. And his cognition did seem to be below average, which would be explained partially by his developmental delay history. And so diagnosis-wise, here is what the likely culprits were. We have a diagnosis of obsessive-compulsive disorder and developmental delay. These are both well evidenced by the criteria that he meets and his medical history. But there's also in the differentials risk of social anxiety disorder and autism spectrum disorder. Both were noted by therapists in the past, and he has a family history of social anxiety. And so while social anxiety may be its own diagnosis, it actually may not be. Because his fear presented less like a classic example of social anxiety and more like a specific fixed fear of bullying. And his response was quite extreme and rigid, leading to total isolation, a refusal to go to school. And so this could be an interesting manifestation of his OCD rather than a separate diagnosis of social anxiety. And autism spectrum disorder does seem like a reasonable differential as well, with rigidity of behavior, some lower intellect and social deficits, but it's not able to be totally teased out from the OCD and developmental delays, and that would require additional evaluation as well. But overall, his OCD and developmental delays were clear, and together they would explain all of his symptoms despite other reasonable differentials. And so it was decided to increase his sertraline to 100 milligrams daily and to encourage compliance. And he also was requested to have follow-up in 3 to 4 weeks. He was referred to a psychologist specializing in OCD for cognitive behavioral therapy and exposure therapy. And he was also recommended to establish with a PCP to continue managing his other conditions for allergy testing and to possibly direct him towards autism evaluation as well. And if we can go to the next slide, we can see the outcome over 6 months. So he did gradually increase his dosage to 150 milligrams after some visits, and did attend 4 sessions of the therapist that we referred to. He did have marked improvements. So he was able to open a trash can, he was able to wash his hair, enter the pool. He's been eating a greater variety of foods and using less toilet paper. So there were concrete improvements, and we were able to address some of the behaviors he was participating in. But unfortunately, because of a change in insurance benefits, he resulted to that resulted in transition to a non-UTMB clinicians for ongoing care. So at that point, our involvement with this case was finished. But from the diagnosis made and the treatment made in response, it does seem, at least at the 6-month mark, that there was some improvements made. And so with that, Dr. Shotwell can kind of take over and talk about the rest of the case.
Sure. Thank you for that great presentation, Jonathan. So what are some of our key takeaways from this presentation? Well, first thing, OCD symptoms can be variable. Often people come in and they have a mixed presentation with a variety of obsessions and compulsions, and those things can actually change over time as well. Something else Jonathan mentioned, OCD overlaps a lot with other psychiatric conditions. Sometimes it's difficult to tease it apart and give a definitive diagnosis when the differential is so broad. Something else is OCD symptoms for many patients have been going on for a very long time before the family actually seeks help. What usually prompts families to come in is when the time-consuming nature of OCD becomes so involved, and the family is spending so much time relative to the patient's symptoms that they finally decide to come in and get it treated. And then the other thing Jonathan mentioned is psychiatric medications don't work if you don't take them. So this patient had been on very low dose sertraline for over a year and a half. He had poor medication compliance, and so he was never adequately treated from a pharmacologic standpoint. And it is important to note that OCD itself often requires higher doses of SSRIs relative to other disorders like major depression or anxiety disorders. So what is OCD? For most people, OCD is what's depicted in these pictures. So the public mostly thinks of people with OCD as being perfectionistic or germophobic. Many people also use the term OCD when they're actually describing people who are OCPD. And even though there is some overlap between these conditions, they are not the same condition. So OCPD, as the name implies, is a personality disorder. And those traits of orderliness, control, perfectionism, those are long-held and stable personality traits in contrast to OCD. So in OCD, the traits and behaviors tend to be distressing, and the behaviors also tend to fluctuate a lot over time and in relation to various anxiety levels. So why does the public think of people with OCD being perfectionistic or germophobic? I suspect a lot of it has to do with the way that people with OCD are often portrayed in the media. So here are just a few examples of movies and TV shows where at least one of the main characters has OCD. So on the far left, think of Sheldon from Big Bang Theory. He was very particular about sitting in a certain spot on the couch. He was highly germophobic. He also displayed some compulsive behaviors and his ritualistic ways of knocking on the door exactly 3 times, saying the person's name each time he finished knocking. Another series where the person had OCD was Monk. I haven't personally seen this series, but as you can see just from the advertisement for the series, OCD is front and center in this series. And then we have the movie The Aviator, where Leonardo DiCaprio, he played a billionaire, Howard Hughes, in the film. And many of the OCD behaviors depicted in the film were actually based on Howard Hughes' real-life contamination-related OCD. And then finally, this is a little bit older film, but some of you may still be familiar. As Good as It Gets. This focused heavily on the main character's contamination-related OCD symptoms. So how do people with OCD see themselves? I have a little movie here. As I explained to Miss Laura at the beginning, I'm going to wait and play this movie at the end, just so we don't get disrupted in the PowerPoint slides. But it's actually a really cute video where a couple of minutes, there's several children describing their OCDs in their own words. So it's a very cute video. We will save time for it at the end. So how does the DSM-5 define OCD? Here are the diagnostic criteria. I do want to point out that OCD requires the presence of obsessions, compulsions, or both. Emphasis on the word or, and that you don't have to necessarily have both obsessions and compulsions to have OCD. So let's take a look at how they're defined. Obsessions are recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted, and that most individuals causes marked distress or anxiety. These individuals try to ignore or suppress these obsessions or try to neutralize them with some sort of compulsive behavior. In terms of compulsions, they're really defined as repetitive behaviors or mental acts that an individual feels driven to perform in response to their obsession. These behaviors, they really aim to prevent or reduce anxiety or distress or prevent some dreaded event or situation. However, these behaviors or mental acts are not connected in any realistic way to what they're meant to prevent. Or if they are connected, they're clearly excessive for what most individuals would do. I also want to point out that the DSM-5 specifically states that obsessions and compulsions should be time-consuming and causing clinical distress. So many people with OCD have OCD traits or they experience periodic OCD symptoms, but they don't reach the threshold of what we would consider representing a mental health disorder. I also want to point out that the OCD specifiers are based on the degree of insight that the individual has into their symptoms, and options for specifiers are good, fair, or poor insight, or absent insight, or delusional beliefs. So here are just a few of the possible types of obsessions that an individual with OCD might experience. This list is in no way comprehensive, but it's more meant to demonstrate how variable the presentation of OCD obsessions can be for patients. So as you might expect, contamination-related OCD is commonly recognized by the public, and it's often something that brings patients in for treatment. And the second example was part of our case presentation earlier. Our patient had a fear that he would choke on food, and also a fear that the food was unsafe and that he would suffer an allergic reaction. One that we discover a lot when we're evaluating patients for OCD is the presence of unwanted sexual thoughts. For example, someone may be having inappropriate sexual thoughts about a family member. Sometimes people are embarrassed to bring this up, and so it can easily be missed, especially if you aren't asking about it. Fear of something bad happening to a family member is a common presentation of OCD, particularly in young children. For example, you might have a child that feels like they must pray a certain amount of times per day for their family member. And if they don't pray and something bad happens to that family member, they're going to assume it was all their fault. So they're attributing blame to themselves for a situation that clearly is outside of their control. Another example is perfectionism. So you might think of OCPD when you hear this. So let me give you an example of a patient that I saw before. So I had a student that was actually referred to me through the TCHAP program. She was a straight A student who started to struggle academically in math due to low test scores. It turns out when talking to her that she would only complete a few questions on her exam, And then every time she ended up running out of time. And because she only completed a few questions, she ended up getting a low grade. She knew the material, but she just couldn't seem to finish the assignments. So when I spoke to her and I asked her what she was doing with all of that time, it turns out she was repeatedly erasing the answers and rewriting the numbers until they looked perfect. And this ended up taking so much time that she wasn't able to finish her exams. So this patient actually had OCD. And I worked with this family to set up some 504 accommodations at school to help ensure she had adequate time to finish her exams. And I also recommended some psychotherapy for her OCD symptoms. So those were examples of obsessions. What about compulsions? Well, compared to obsessions, compulsions and OCD, they may be a little bit easier to recognize. These are the outward manifestations of OCD that are often identified by family and often prompt treatment. So these are just a few examples of different compulsive behaviors you might see in patients with OCD. I will point out that engaging in compulsions is one of the areas where people with OCD spend a lot of their time. So as I mentioned before, excessive hand washing is one of the most recognized compulsive behaviors. This was definitely a compulsion that was reinforced a lot during the COVID-19 pandemic, where we were insisting that everyone wash their hands as many times as possible on a daily basis, just to prevent spreading the virus. Many of my patients with contamination-related OCD actually seem to do better during the pandemic. If you think about it, during that time, we had hand washing, physical distancing, people were wearing masks, people were wearing gloves, there were physical barriers in a lot of places that my patients with OCD contamination-based fears, they were feeling much more comfortable in that environment. They felt like people all along should have been engaging in those behaviors to prevent the spread of germs. Another one is checking behaviors. This is also one that's pretty common. Think of a person getting up to check their doors, their door locks repeatedly, just to see if they're locked. They know they're locked, but despite knowing they're locked, they feel compelled to get up and repeatedly check the locks just to make sure that they're locked. Another one patients commonly say is, especially adult patients, worrying about leaving the stove on to the point that they'll be on their way to work, and they'll have to turn around and drive home to check their stove just to make sure that it's off. Another one is counting. So I've had patients come to me for ADHD evaluations, only just to discover that they actually have OCD. And it turns out the child will be spending so much of their time counting in their head that on the outside, they appear distracted, inattentive. They may seem like they have inattentive ADHD, but it's really OCD. And it's really important, if that's the case, that we recognize it, because the treatment for inattentive ADHD and OCD are very different. The constant need for reassurance, that's also something that brings patients in for treatment, and it can significantly impact the parent's quality of life. So I've had lots of parents bring their child in because the child is constantly text messaging or calling the parent to the point that the parent's unable to function, unable to work, and it's really disruptive for family life. And then finally, avoidance is often a coping mechanism used in OCD. People with OCD may avoid thoughts or situations that might trigger their obsessions. For example, I had a patient that had intrusive thoughts about stabbing a family member with a knife. Because of this, the patient refused to go into the kitchen. She didn't want to be anywhere around knives for fear that it might trigger her intrusive thoughts or worsen them. So these are just a few of the examples of how compulsions might present in a patient with OCD. So we've seen that the presentation of OCD can be variable, but just how common is OCD? So the 12-month prevalence of OCD in the US is around 1.2%. Females are much more likely to have OCD than males. The average age of onset is around 19 and a half years. with males often presenting earlier than females. We know that exposure to trauma early in life may increase the risk of developing OCD. Certainly, we know genetics plays a role as well. So having a first-degree relative with OCD increases the risk of a child developing OCD. And earlier onset OCD is generally higher severity. So if the family member had early onset OCD, this also increases the risk tenfold. So family history is really important when you're evaluating these patients. I will point out that there is also the possibility of developing a form of OCD that's rapid onset, high severity, and that is in individuals who develop PANDAS, which is pediatric autoimmune neuropsychiatric disorder associated with strep infections. And this is thought to be autoimmune antibodies mistakenly attacking certain parts of the basal ganglia following a streptococcus infection. So that results in OCD symptoms that are high severity, rapid onset, and pretty debilitating for the patients. So what prompts people with OCD to finally seek treatment? These are just a few of the reasons that people with OCD might come in for help. As I mentioned earlier, OCD is a very time-consuming illness. It can be time-consuming for the individual, but it can also be time-consuming for the family. People with OCD, they often have a lot of anxiety. They have difficulty sleeping. Mood disturbance is common. Physical symptoms are also common for patients coming in with OCD for treatment. This may be one of the reasons that a patient might come in to see their PCP. Maybe they're washing their hands excessively to the point that they've developed some sort of dermatologic condition. Patients with OCD may also engage in self-harming. So that might be a way that a patient distracts themselves from their OCD symptoms. And it might not be until that self-harming occurs that they come in and seek treatment or seek evaluation. Something else you'll notice as being a primary care doctor, pediatric patients with OCD, they may have a lot of difficulty attending school. And so school refusal or school attendance problems may be one of the reasons that parents bring these children in. And as I mentioned earlier, avoidance is a really common compulsion in OCD, and family members may grow tired of a patient's avoidance when it starts impacting the family's life. So as Jonathan mentioned earlier, OCD can be challenging to diagnose sometimes. There's a lot of overlap between OCD and other psychiatric conditions. And OCD is often comorbid with other psychiatric conditions. For instance, OCD and anxiety, they often overlap. It's important to distinguish the two because the therapy interventions for OCD, they're more specific than they are for anxiety. And I will point out when people have anxiety disorders, the worries tend to be more about real life concerns, and there doesn't tend to be the compulsive behaviors involved. Major depression is another one. So the negative ruminations that people tend to have in depression, those are more mood congruent, and they don't have necessarily the compulsive responses that you would expect for someone with OCD. So we talked a little bit earlier about OCD versus OCPD, the personality disorder. As I mentioned, even though those names sound very similar, those are actually very different conditions. So people with OCPD, they don't have obsessions and compulsions. Instead, they have an enduring, long-term, pervasive, maladaptive pattern of excessive perfectionism and rigid control. As I mentioned in our case earlier, OCD can be challenging to distinguish sometimes from autism, particularly in those who have social deficits or some sort of developmental delay accompanying their OCD symptoms. OCD-related disorders, they tend to have a narrower range of symptoms, and those symptoms tend to have less evolution over time compared to when someone has OCD, where evolution of the symptoms tends to be the norm. And I will point out, in case you didn't know, there is a differential diagnosis section in DSM-5. that will help you differentiate OCD from other psychiatric disorders. So it goes through each of the disorders and it helps explain how those disorders are different from OCD. So from a diagnostic perspective, that can be pretty helpful. All right, so clinicians often struggle to figure out how to ask about OCD symptoms. Because the presentation is so variable, sometimes it's hard to know how do you ask patients about it. So these are just a few example screening questions that I personally use when I'm talking to patients about OCD. So, do you ever get thoughts stuck in your head and you can't make them go away? Do these thoughts make you feel worried or stressed out? So that's kind of one of the ways that you might ask about obsessions. And then do these thoughts make you feel, do you find yourself repeating certain behaviors to make yourself feel better? That might be one of the ways that you talk about compulsions. That might be one of the ways to ask that question. Sometimes it's helpful if you have a patient with OCD if you give them some examples. So they might have a hard time understanding the concept of OCD symptoms. So using examples can really help with that. So one example would be, do you worry a lot about getting sick or being exposed to germs? Does that make you have to end up washing your hands more than normal? Do you worry about something bad happening? Is the only way that you can make yourself stop worrying about something bad happen is to get up and check the door lock. Even though you know it's locked, you just find yourself checking it over and over and over. So kind of helping them to understand what the obsessions are, what the compulsions are, and how those two interact can be helpful to get the conversation started. If you're looking for something more formal than just my personal screening questions, there are screening tools out there that can be used to screen for OCD in patients. One of the most commonly used scales in OCD clinical research is the SciBox, or the Children's Yale-Brown Obsessive-Compulsive Scale. In its original form, this is a clinician-administered, semi-structured interview involving both the patient and the guardian. And so I'll go through a little bit more information about that on this next slide. So when you're administering these SciBox, the first thing that you're going to do is you're really going to define for the patient what is an obsession, what is a compulsion. And you're going to give examples, just like we talked about earlier, to make sure that the patient fully understands what you're asking. A OCD symptom checklist, you're going to go through one of those where you're going to talk about all the different types of obsessions and compulsions and kind of quantify which ones are occurring in the patient. From that OCD symptom checklist, you're going to identify the 4 target symptoms, and then you're going to have the patient go through a symptom severity rating scale, rating each of these individual symptoms on a 0 to 4 scale. So in total, your SciBox score can be anywhere from a 0 to 40. The higher the score, the higher the symptom severity, the more impairing the OCD symptoms are. So, just in this little bit that I've talked about it so far, you can probably appreciate this is a little bit time consuming. It might be difficult if you're in a primary care setting to be able to have time to administer this. And then I'll also say this is something that you would have to practice a little bit before you did it, because there are several steps involved. You want to make sure you're really comfortable with administering this before you try to do it in the clinical setting. So I will also point out there are self-report versions of the SciBox available. You can pull them offline. You might consider one of those just as a way to kind of comprehensively gather information about obsessions and compulsions that your patient might be experiencing without having to go through and do a clinician-administered SciBox. So I'm going to bring up the self-report symptom checklist, and we will review that at the end of these slides. So now that you've identified that a patient has OCD, you get to the point where you need to treat them. So as with most conditions in childhood, the preferred pharmacologic agent for treating OCD is an SSRI. There are 4 SSRIs that are approved for treating pediatric OCD. I just want to point out there's no approval for citalopram or escitalopram. So the ones that are approved are fluoxetine, fluvoxamine, sertraline, and then there's no approval for citalopram or escitalopram. And you can see there are FDA-approved age ranges listed on the slide, so you can see what age range is appropriate to use each of these medications. So what do you do if you try an SSRI and it fails? You try another SSRI. So I want to make sure to point out that an adequate trial would be at least 6 weeks on the medication at an appropriate dose, providing some symptom relief. And as I mentioned at the very beginning of the presentation, OCD often requires a higher dose compared to other conditions. So don't be afraid in the patients that you're treating to increase the dose if needed. If you get to a point where multiple SSRI trials fail, so you've tried the adequate dose, adequate time, it just hasn't been effective for your patient, something else that you can consider using is clomipramine. Clomipramine is a strongly serotonergic tricyclic antidepressant that's used a lot for treatment-resistant OCD. And as you can see, it is an approved treatment in individuals aged 10 to 17, and then obviously adults as well. So in terms of treatments, there was a large meta-analysis back in 2003 where they looked at SSRIs in general, compared them with clomipramine, and then also compared that to placebo. It was a pretty large study where they looked at over 1,044 participants who were in 12 different studies and included them in the analysis. The SSRIs that were included in the study were sertraline, fluvoxamine, fluoxetine, as well as paroxetine. And I will point out that paroxetine is not FDA approved, but it was also included in that research study. Findings were that the SSRIs were more effective than placebo. There really wasn't a preferred SSRI for treating OCD. They pretty much all performed the same. And then I will point out that clomipramine was better than the SSRIs. But one of the reasons that we don't often use it first line is really its side effect profile, which we're going to talk about a little bit more on the next slide. So just some things to think about when you're thinking about OCD pharmacotherapy. So when you're using SSRIs, you really want to start low, go slow with the dose titration. It is pretty common for people to experience side effects when they start an SSRI. Lower doses can really help to reduce the risk of developing a side effect. Most of the side effects tend to be transient. It's really important for you to educate your patients on the transient nature of the side effects and encourage them to continue the medication even if they happen to experience a side effect, because if they stick with it, it's likely the side effect will subside. Let parents know about the black box warning for antidepressants. What you don't want to happen is for the parent to go pick up the medication from the pharmacy, the pharmacist mention the black box warning, and then the parent be too scared to give the medication to their child, and then therefore there's no treatment. So if you educate them about this ahead of time, you can help them to feel more comfortable in starting the treatment when they get it. Like I mentioned earlier, you often need higher doses of SSRIs to treat OCD, so don't be surprised if you have to push the dose up. If you have someone, for example, on Prozac, you might find yourself needing a dose of 60 or 80 milligrams. If you have someone who's on Zoloft or sertraline, just as we mentioned earlier with the case presentation, that patient needed a dose as high as 150 milligrams. So sometimes you need to use 150 or 200 milligrams of that particular medication. If you decide that you're going to use clomipramine, you really need to pay attention to the family history. You need to screen for the potential family history of cardiac problems. It's suggested that you get a baseline EKG, and then anytime you're going to be making any major changes in the dose of the clomipramine, it's recommended that you repeat the EKG just to make sure that there's not any cardiac risk there. If you're concerned about it, there is the ability to obtain clomipramine levels. And so you can always check a level to make sure that your patient isn't getting toxic. And then tricyclic antidepressants like clomipramine, I'll point out they're strongly anticholinergic. So side effects really tend to be one of the limiting factors for their use. And if you think about anticholinergic side effects, a lot of sedation, a lot of constipation, those are just a couple of the ones that patients routinely complain about. So I also want to point out OCD can be effectively treated using psychotherapy. So especially if a patient has mild OCD symptoms, you might consider using psychotherapy rather than pharmacotherapy. Patients who have moderate to severe OCD, they may actually find benefit from combining therapy with pharmacologic treatment. So the treatment of OCD using therapy, it's called exposure and response prevention, or ERP therapy. And in ERP therapy, the way that that works, kind of high level, the therapist starts by developing a hierarchy with the patient of their obsessions and compulsions. And then they engage in exposure therapy with the patient, at the same time preventing them from being able to engage in those compulsions that they would typically do for their OCD. So just a clinical example of that, if you had a patient who had a contamination fear, one of the things that they might do in the exposure therapy is ask the patient to expose themselves to germs. So they may have the patient take their hand, put it on the floor. So that's the exposure part of it. And then the typical response that the patient might have to their contamination fear is to wash their hands. So if you're doing like exposure and response prevention therapy, you might have the patient take their hand, put it on the floor, but not really let them wash their hand after they do that. So that's the response prevention part of it. So what if we kind of compare which is better, medication or therapy? So they've actually done some studies on this. One of the large studies was called the POT study, or pediatric OCD treatment studies. This was a randomized placebo-controlled trial where they compared CBT, specifically the exposure and response prevention, with sertraline. And then they also compared that to patients who received both CBT and sertraline. There were 112 patients with OCD who participated, ranging from 7 to 17. They all were had a DSM-4 diagnosis of OCD and a SIBOX severity rating of at least 16. And the way that they were evaluating whether the treatment was effective or not, where they were repeating the SIBOX at the end to see how much it changed in response to the intervention, whether it be medication, therapy, or medication and therapy. So what did they find? Well, all of the treatments were better than doing nothing. So all the treatments were better than placebo. As you might expect, combined treatment using both therapy and medication led to the greatest symptom improvement. You can also see that clinical remission was possible for a lot of these patients. So it was achieved in greater than 50% of the patients who had both medication and therapy. Therapy alone was superior to medication alone, and this would suggest that we should probably consider therapy the first-line treatment for OCD in children. Of course, we all know as clinicians, one of the limiting factors for that might be the ability to find a therapist who can do that particular therapy. And side effects were really one of the reasons that people on the treatment side using medication, that was one of the limiting factors there. So side effects from the sertraline, nausea, vomiting, abdominal pain, but nothing serious beyond that. All right, so I just want to end by reminding you that there are resources out there if you have patients with OCD and you need help. You can always contact the CPAN hotline and consult with one of the child psychiatrists and get advice on evaluating a patient with OCD. They can also help you locate resources for patients who need therapy for their OCD. If you're fortunate to be in an area where you have access to T-chat services. You might find that you can get your patient in for T-chat and they can do some therapy or meet with a psychiatrist for that, depending on the area. Another resource that I wanted to bring to your attention is the International OCD Foundation website, which has resources on there. One of the resources is a directory of therapists in your area who provide exposure and response prevention therapy for OCD. So if you're having difficulty finding a therapist, you can either reach out to CPAN, they can help you with that, or the International OCD Foundation also has a list of therapists on there as well. And these were the references for the presentation today. I'm going to go ahead and end the slideshow. All right, so I wanted to quickly play the video of the children explaining their OCD symptoms.
And then we do have a question in the chat for you too, Dr. Shotwell, when we're done with the video.
Yes, ma'am. Is the video visible on the screen for you now?
I see
can see
the
it.
black screen that says obsessive.
Okay, so I'm going to go ahead and start it, and you should be able to hear it.
OCD is obsessive-compulsive disorder. It's obsessions and compulsions. An obsession is an unwanted thought, and then a compulsion is something that you have to do because of that thing. If something hits, it's like I hear something this ear, I don't want to hear something this ear. Or if something hits this hand, I don't want to hit it this hand. I would have to do things in evens, like in an even amount of times, like 2s or 4s, but I could not do 8. I'd avoid things that I thought were poison, which was like gum wrappers, litter. There were like tiles in the hallway, so I had to like walk on only in certain tiles. And then I used to have to read the tags on my clothes a certain amount of times. I'd turn the light switch on and off and on and off and on and off. If I touched the iPad, I'd have to touch my dad and like blink a certain amount of time so he gets the contamination instead of me. So I kind of sacrifice him. You think once I do the ritual, I would be thinking about the obsession and then I'll feel better. And then something else, OCD, like another OCD ritual pops up and I'm like, oh no, seriously, I just got done with the last one.
Yeah, so that's a cute little video of patients explaining their own symptoms. And then I'm just going to quickly show you something else, and then I want to save a minute for questions as well. So this is what I was pointing out earlier in the presentation, that there is a self-report checklist for OCD symptoms. So obviously it would be difficult to have time to go through and ask about every single one of these obsessions and compulsions in the clinical setting when you're working with the patient. So using a checklist like this can help you kind of narrow down those symptoms that patients might be experiencing, which might allow you to have more time to focus on the specific ones that are going on with your patient, but also allows you to be aware that the other symptoms are there and you can follow up on them.
Dr. Shotwell, I also am going to post that YouTube in the chat. So if folks want to take a look at that later, they can go back and review it.
Sure, that would be great.
Fantastic.
Okay, I think I'm totally out of screen sharing mode. And so you said there was a question in the chat.
There is. It's from Dr. Davis. He's a pediatrician actually here in our area. And the question is, what is the rate of overlap of OCD with other neurodivergent neurodevelopmental conditions?
Yeah, I think it's probably pretty high. I don't know the exact number off the top of my head, but certainly the presentations can be difficult sometimes to distinguish from one another. So for instance, if you have a patient coming in with autism spectrum disorder, particularly if they have a lot of repetitive behaviors or they're kind of fixated on certain things, that can sometimes be clinically difficult to distinguish from OCD because there is a lot of overlap there. And actually at UTMB, our specialist who we refer patients to for OCD, we also refer our autism patients to that same specialist. The same person who does the exposure and response prevention therapy also works a lot with our patients who have autism if that's one of their most problematic behaviors that they're coming in for. So yeah, I definitely appreciate there's a lot of overlap there, and clinically it can be difficult to distinguish the two. I think the defining feature for a neurodevelopmental disorder like autism would be the social deficits that also accompany it. But just like as in our presentation today, that case presentation, there were a lot of social deficits there. So it can be difficult sometimes to distinguish those. That's a
And
great
then,
question.
do you have a link for that checklist?
Yeah, I can certainly send it to you. And that way everybody can have access to it. Yeah, I have it saved on my computer as a PDF, but I'll send you the file in case you want to distribute that.
All right. If anybody would like that information, you can contact me. I'll go ahead and put the CPAN email address in our chat, and you can reach out to me that way if you'd like a copy of the slides as well. Dr. Shotwell is always really good about sharing the slides. Knowledge is power, and we certainly want to provide you with as much knowledge in child and adolescent mental health as we can through CPAN here.
Definitely. I was trying to pull the PDF and see if I can add it to the chat, but it just doesn't want to drop on there. But I'll email it to you.
Sounds great, Dr. Shotwell. Any other questions? You can certainly unmute yourself if you'd like to ask a question. I did mute some of you as you came on because you were on your cell phones. Okay, another question. Did you see it, Dr. Shotwell?
Yes. So do you have any information on the taste of liquid sertraline? I treat many patients with ASD and ARFID as well. So yes, in general, I always encourage patients, if they can, to take their medication in pill form. I think as much as the drug companies would like to think that their medications taste okay for the patients when they add flavoring, I would say almost all patients say the medication tastes horrible. And even patients that are on liquid medications, as soon as we can get them transitioned to a pill, we do, because I think it makes such a difference with compliance. I think they're much more averse to the liquid medications, mostly for the taste. And then the other thing to keep in mind, with these OCD patients, we're going to be sometimes using very high doses of medication. That translates to a lot of liquid. So suddenly it's not a spoonful. It may be one of those little small pharmacy cups full of medication or two. And so I think that's something to keep in mind as well.
Great. Any other questions? Elizabeth Rodriguez-Ling had a second question there.
Yeah, so she said the other thing with sertraline is it's very concentrated. It needs to be mixed with another liquid, but not milk, or else it can create some temporary anesthesia on the tongue. So I'll be honest with you, I don't use a lot of liquid sertraline. Most of the time, if I'm using sertraline, it's a tablet form. I will encourage patients to do everything they can to be able to use the tablet. I usually tell the family, buy some Tic Tacs, let your kid practice swallowing the medication, swallowing the Tic Tac like it's the medication, practice it. The more you practice it, the more likely you'll be able to do it. And most patients, we can get to a point where they're taking the pill form. And then keep in mind, you can also chop that sertraline pill up pretty small. You don't have to take it whole. As long as you get the whole pill in at some point, you can break it up into 2 or 3 pieces.
I am going to show the rest of the year's CPAN CMEs. Again, that way if folks would like to take a look at what we're having here, they can. Dr. Shotwell, there's also a question from Dr. Munda while I show this screen.
Sure. So the question is, if a patient has ADHD and OCD, do you start them on medication for both, one at a time, or which one do you prioritize? I think that's one of those questions that can be difficult to answer because it really depends on the individual patient. So for instance, if I had a patient that their main complaints or concerns from the family were OCD symptoms, and as part of my general assessment, I picked up that there was the presence of some ADHD symptoms, I'm definitely going to prioritize the OCD first, or vice versa. So I think you have to kind of take into account what is the patient coming in for, what is the family most concerned about, and kind of prioritize that as well.
Thank you. Are you able to see that list of CMEs, Dr. Shotwell?
Yes, ma'am. I can see
Okay,
that.
it's this new version of the PowerPoint has definitely got me going here. What you won't see on this screen is we will be having a fall echo series for Project Echo on CPAN as well. We are actually meeting on Friday to finalize the plan for that as far as start dates and such. So if you are wanting additional education along with what you see on the screen here, we will be having Project Echo. If you're not familiar with Project Echo, if you just type in Project Echo into YouTube, you will find information about that. It's a great learning experience. We talk about different cases and such like that as well. And I think you will find that to be a great help for child and adolescent mental health in your primary care setting. We are 1 minute over. Dr. Shotwell, thank you so much for your time. And thank you all for joining us today for our CPAN CME on OCD assessment, treatment, and primary care. Next Tuesday, we do have an ethics session, which is why improving access to mental health care is an ethical imperative. That will provide you with ethics credits. And then in August, we'll be talking about managing complex ADHD in primary care. Thank you again all for joining us today. I'm going to stop sharing that screen. And if you have any questions at all, please reach out to us here at CPAN, either at your hub outside of Tyler, if you're with the hub down in Galveston or another hub, or reach out to us here in Tyler. We'd love to help you. Y'all have a fantastic day and a great rest of your July. Bye-bye now.